If they've got an MRI back that says a partial tear, tendinosis, or something that sounds scary or surgical, and now you're wondering if you're done running. I want to tell you a little bit about Courtney. Courtney is the ultramarathoner who had social Achilles tendinopathy and bursitis and a Haglund deformity and a cyst in the tendon. The doctors at the Steadman Clinic, one of the best in the country in Colorado, told her that she needed surgery to shave down the bone. But she turned down that option, and today she's running more miles than she ever has. Pain-free, no surgery. So today I want to walk you through when surgery is necessary and how Courtney was able to overcome it. Here's what makes this question so important. We're just not asking about a medical procedure, right? We're asking if your running life is about to fundamentally change. And when a doctor uses words like tear, degeneration, or structural damage, or partial tear, or tendinosis, it's easy to assume that the answer is binary. You either fix it surgically or live with it forever. But tendons don't work that way. Most Achilles injuries, even the ones that look rough in imaging, don't necessarily require surgery. What they require is a smarter loading exercise plan. So let's talk about when surgery is the right call and when it's not. And I'll show you exactly what we did with Courtney to rebuild her Achilles without having to go under the knife. Let's start with the truth. Surgery is necessary sometimes, but not as often as runners think. Here's the actual criteria that most sports medicine surgeons use when deciding when surgery makes sense. 1. When you have a complete Achilles rupture, that's usually a surgical intervention, though increasingly we've been seeing more doctors take the non-surgical approach, and I'll make a whole other video on that another time. The good news is that most runners won't ever have to worry about a rupture while running. Running itself is a sport that doesn't cause the mechanism that you need in order to rupture your Achilles, like in football, basketball, or soccer. 2. Chronic tendinopathy that hasn't responded to at least 12 months of structure and consistent rehab. And I mean structure, not YouTube videos or calculations here and there, not rest or stretching. I mean committing to a progressive tendon loading with a running integration for at least 12 months. If you've done that for a full year and you're still not improving, then that's when I would encourage the runner to have a conversation with the surgeon. The reason being is that it takes tendons a full year to fully regenerate and restore its ability for full function. 3. If you have a significant insertional tendon pain causing mechanical impingement, such as where a large Haglund deformity or calcification or even a posterior ankle impingement, which are physically blocking normal joint mechanics, that's when surgery could be a conversation because those structures are impinging or they're rubbing on the Achilles, and that can make it really sensitive and painful. But even then, surgery in those cases target the bone, not the tendon itself. In Courtney's cases, her Haglund deformity was small enough that while the doctors recommended surgery, we thought that it didn't necessarily mean that she needed surgery. So that's a very individual conversation that you need to have with your surgeon, with your physical therapist, athletic trainer, or a coach like myself. Because here's what automatically doesn't mean surgery. If you have tendinosis, tendinopathy, they're pretty much the same term. When doctors explain it, they call it partial tear because when you look at the MRI of a tendon, it looks like there's a tear, the white spot, there's fluid in there, and it looks like a tear, right? But it's really not. What's happening here is that the tendon is so deformed and disorganized that it shows up in tear. And tendons also have a massive immune system response when that happens. And that brings about a lot of fluid as well. So that can show up on an MRI and make it look like it's a partial tear. In addition, thickening of the tendon, small cysts, or pain that fluctuates or only spikes during the after activity are not surgical intervention. They're actually opportunities for rehab. Most marathon runners, triathletes, and ultramarathoners dealing with Achilles tendinopathy fall in that second category and rarely see a tendon that absolutely needs surgery. Imaging can be scary, and words like tear also sound scary, but if there's one thing you can take away from this video, it's that the tendon still has the capacity to adapt. It just needs time. It needs love. It needs consistency. So therefore, the question isn't, do I need surgery? The better question is, can my tendon rebuild capacity if I load it correctly? And most runners, the answer is yes. Let me tell you a little bit more about Courtney because her case is a perfect example of why imaging doesn't tell the whole story. She came to me after seeing some of the best sports medicine doctors in the country as well as physical therapists, and her MRI showed a fourfold injury: Achilles tendinopathy at the insertion site, retrocalcaneal bursitis, and Haglund's deformity, and a small cyst in the tendon. The recommendation was surgery, specifically to shade down the Haglunds. But what the imaging didn't show was that Courtney could still run. She was an ultramarathoner, and she could put on some serious miles. She can still load the tendon. She had to cross-train for the most part, but it felt fantastic when she did that, and her tendon didn't fall apart with normal daily movements. And this told me something really important, that her tendon wasn't mechanically failing despite all that was going on inside her heel. It was being compressed and irritated by positions and loading that she wasn't ready for. So instead of surgery, we built a plan around one principle. First, we avoided any dorsiflexion loading, such as deep stretching or deficit heel raising, and we built her capacity by strengthening the Achilles tendon. So instead of doing eccentric heel drops, or aggressive calf stretchers, or uphill running, or excessive running, for that matter, we started to incorporate isometrics, heavy, slow resistance training, especially during the pain-free motion, and we simply just stuck with the progression over time. And 6 months later, she was killing it. On her Instagram, she was showing off her ability to climb 10,000-foot peaks, and she is running ultra-marathon miles. That was just amazing effort she's gone through. So I'm going to show you the step-by-step plan inside the app, the Force Running app that I use with all my clients to help them build progression and a plan that helps get that capacity back in tendon. So let's take a look. I'm going to turn to my computer over here. Alright, so I want to dive into Courtney's plan inside the Force Running app. This is a really cool app I use with all my clients. This is how I can design and progress runners based on their specific situation. So really, in Courtney's case, at the time back in June of 2025, she couldn't run that much. So we had to compensate by using the elliptical and the bike just to maintain her cardio and time on feet, especially on the elliptical, which was key for her goals as an ultramarathoner. And then we started loading the Achilles tendon gradually. So this is the program that we use. So I'm just kind of walk you through some of the exercises that we did here. So the first phase that we started off here are isometrics. I like to start with isometrics to see if we can get some muscular contraction out of the calf without irritating the tendon, especially with her insertional Achilles tendinopathy. We want to avoid any excessive stretching or ankle dorsiflexion in this case. So with the 2 light isometrics, I started with 45 seconds, 50% long rep max. So we estimated it at 20 pounds. That's about, so her long rep max, the isometric is 40 pounds. So we did that, and we did 5 sets of that, and then we did a floating heel hinge. I'm going to put a demonstration of the floating heel hinge here. You can see how I do this exercise. The idea here is that you're essentially lengthening the calf muscle and the hamstring, the posterior chain of your body, which will help support strength in the Achilles. The half-puff pronation is another great exercise. Typically, I do a full foot pronation where we're moving the knee completely over the big toe. But in our case, we want to avoid dorsiflexion or stretching of the Achilles, so we did half foot where the knee stopped right before it went over the big toe. So that's an important difference there. So this exercise is designed to increase ankle mobility and teach the foot how to connect with the ground again. Because that's another video for another time. But that is something that many people struggle with. We did a heel raise off step. Now here it is important. We did it off the step, but I advised Courtney here not to let it lower beneath the step as stress the Achilles. Again, we're avoiding Joseph lesson here. We're just using the step as a floating mechanism and increase the lever and mechanical lever and build strength in the Achilles. So that was the first phase here. We did that for a couple of weeks, and then as part of her progression, we also did heavy slow resistance training, which way to get under the bar as heavy as you can. The key component of the TNT training is tendinopathy training. Is you want to go heavy, which is what we talked about here, but also we want to go slow. And I emphasize 6 to 10 second reps. So it could be 3 to 5 seconds up, then 3 to 5 seconds down. And that slow part is where tendon will actually deform. And we want to deform a certain percentage, 3 to 5%, to trigger that healing process, trigger that collagen regeneration process. And then when we do the next exercise, this is really important here. You have to take 2 or 3 days of recovery after that. Not because it's going to be sore or whatnot. It needs time to regenerate and recover. And then when you do the next exercise, you go into the same process, and then the tendon will regenerate and build new collagen and reorganize tendon, and more importantly, it reduces sensitivity in the tendon because it drives the fluid out the tendon, and it tells the immune system it basically directs the immune system to do just one thing, to repair the collagen and get out. Because when most people have Achilles tendon pain, the reason why they have pain is because the tendon is disorganized. There is just a chaotic immune system activity in there that also brings in fluid, and that fluid irritates the nerves that sit outside the tendon. And you have to keep in mind that tendon itself do not have nerves inside them. So by organizing this process and using this TNT heavy slow resistance training method, you really calm down the tendon. That's really the goal here with Courtney. So we did that for a couple of weeks, and then as we progress, you can see we then added an insertional Achilles tendon protocol. We continue the half foot pronation. We did a 1 leg isometric hold. We added a soleus slouch, which targets the soleus. If you want to strengthen the inside calf muscle that attaches the Achilles, because if you look at the anatomy of the calves, the lateral and the medial gastroc and the soleus basically come together at the tendon junction like twizzlers, and they twist around into the heel bone. And they're essentially twizzlers where it will kind of taper out, so that at the top it splits out into the individual muscle, and at the bottom it comes together and then attaches into the calcaneus, the heel bone. So we have to target each one of the muscle to then trigger the load that go through that particular tendon fiber and generate collagen. That way, get the body to activate the healing process and regenerate collagen. So that's how I think about this. Okay, so that's why it's really important to target the soleus as well as the gastroc, which is why we incorporate many varieties of exercises to target these 3 important muscles. And then we added a heel raise for the interior load. This is really important for insertional Achilles tendinopathy. We can't just do, we can do a barbell, and we can continue to do heavy slow resistance training, which is important for the collagen regeneration, but to get the tendon to offload the compression piece of the insertional Achilles, because it wraps around like this, and to target the inside of the tendon it's a concept known as stress shielding, where if you're just doing barbell calf raises all the time, you're only strengthening the outside part of the tendon, not the inside, because it kind of shields that inside part. But anytime you go into dorsiflexion, that outside part is going to compress into the inside part. And the inside part is almost like gel in a lot of cases. And it becomes really, really sensitive. This is why people who have insertional Achilles tendinopathy can have it for years. So we need to address that. And we do that by putting weight in front of us. And by doing that, you change the mechanical angle, and you can tug in the inside part of the tendon. And if you go slow down your reps, you have a greater chance of getting into putting load through all of the different fibers inside the inside part of the tendon. Okay, so that is what we did with Courtney here, and this is what I do with anybody who had insertional Achilles tendinopathy. And then we progress from there. We increase our heavy, slow resistance weight. We progress the insertional Achilles tendinopathy protocol, and we start incorporating running again. So that's Courtney's plan, and it's worked for her and hundreds of runners. I worked with 101 inside of a force Achilles system, and that's exactly what you get. And I'm really proud of the progress that she's made in the program. So how do you know if you're a good candidate for surgery, and if you are curious about whether you just need to do rehab? Well, here's a simple self-assessment that I use with one. Question 1, can you lower your Achilles at all without collapsing? That means, can you do a single leg calf raise? Can you walk uphill? Can you draw easy for 10 to 30 minutes? If the answer is yes, even if you have painless spikes during and after, the tendon has the capacity. If you generally can't do that or bear weight, then that's a different conversation. Question 2, does your pain respond to load management? When you back up intensity or volume, does it calm down? When you ramp up too fast, does it flare? If that's a yes, then that's more a sensitivity than a structural problem. Structural problems would be if your pain is constant and it appears at any time during the day, regardless of what you're doing. If it's unrelenting and doesn't respond to any training at all, that's when we might want to consider a referral to surgery. There's question 3. Have you actually tried structuring and loading, not just resting and stretching? And most runners I've worked with have tried all these things: resting, stretching, random heel drops, hoping it'll get better, but they haven't tried a true progressive loading plan that integrates strength and running in a way that respects the tendon's capacity. And if you haven't done that in the last 8 to 12 weeks, you don't know yet if surgery is necessary. And even, here's the thing, even if you do end up needing surgery down the line, going through a structured loading phase first will make your post-op recovery better. You're not losing anything by trying rehab first. Let's make this practical for your actual training. If you're a marathon runner, the biggest challenge is managing volume and intensity simultaneously. You can't just run easy for 16 months. You need workout, you need long runs. And the key is to build that tendon capacity before you ramp up the weekly mileage intensity altogether. That may mean a 4 or 6 week block where volume stays moderate, but you're doing more strength work and control faster running. If you're a triathlete, you get the advantage of cross-training modalities, but you also have the bike volume that can fatigue the calves as well. So we got to pay attention to that, especially after a hard bike ride. If it's constantly angry, then that's a sign that you need more calf endurance work off the bike. If you're an ultra-marathoner, your game is durability and time on feet. The risk isn't speed, it's cumulative from low over hours. That means that Achilles needs to handle sustained, repetitive, mid-range loading without breaking down. Focusing building on that capacity in training blocks where weekly hours of control then expand gradually. That's where Courtney found her bread and butter because she's an ultramarathoner herself. That's what she did, and she used the elliptical to her runner to help accomplish that. In all three cases, the principle is the same. You're not training around the injury, you're training through it by building the capacity your tendon actually needs. So here's why I focus on this week if you're in this situation. For running, keep it control. Flat terrain, easy effort. If you can run 20 to 30 minutes 3-4 times a week without a flare up, then you're in a good spot and you can consider this to be rehab territory, not a surgical case. Strength. Start with isometric calf holds. Elevate your heels slightly. Hold for 30 to 45 seconds, 3-4 sets per leg. Do this on non-running days. If that feels manageable, add partial range calf raises. Mid-range only, no deep stretch in the bottom. We want to avoid that compression, especially if you have exertional Achilles tendinopathy. For recovery, sleep and spacing matter. If you run in the morning, strength train at night, the tendon doesn't have time to adapt. Spread things out. And here's the mindset shift. You're not trying to make the pain disappear this week. You're trying to prove that your Achilles can handle consistent load. That's the first step. If you can do that, then you're on the path to Courtney choking. You probably don't need surgery. And keep in mind that this advice does not constitute medical advice, and if you have specific questions, always best consult a surgeon or a sports medicine physician. And I get it. When you see words like tear, degeneration on an MRI, it's scary. It feels like something's fundamentally broken. But in most cases, what's broken isn't the tendon, it's the strategy. And that's fixable. We can load the tendon appropriately. If you want to run again with confidence, durability, and strength, watch the workshop below and apply to become with Force Runner today. And you get to work with me one-on-one to figure out the best solution for your Achilles, discover the root cause that may be contributing to this, and figure out why this has been going on for months or years. And it'll help you run consistently with durability and with confidence. Inside the workshop, I'll walk you through the exact framework we use with Courtney and hundreds of other marathoners, triathletes, and ultra runners to rebuild Achilles capacity without surgery, without resting from us, and without losing your identity as a runner. So let's get you back out there and click on the description below to get started.